Welcome, everyone. Again, I'm Michael Udell, the Vice Dean and Professor here at the College of Health Solutions at Arizona State University. And I'd like to thank you all for joining our Health Talks webinar. The College of Health Solutions addresses the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. Health Talks are one way that we serve the community with timely and relevant educational content that also provides continuing education credit at no cost. I'm just going to go through a few quick housekeeping items before we get started. First, please be aware this session is being recorded and it will be posted on our website. You can find it at asuhealthtalks.com. After each of our panelists presents, I will moderate a Q&A session, and please submit your questions using the Q&A feature in Zoom and not the chat box. So I'll be checking the Q&A box, but I will probably not be seeing the chat box because I only can see the host and panelists in the chat box. So please make sure to use the Q&A feature. Finally, you will receive a brief survey asking for your input about today's webinar. If you are requesting continuing education credits, this must be completed in order to receive credit. If you did not apply for CEUs, we would still very much appreciate your feedback to help improve our series. So I am going to jump in and share my screen. Give me a moment here. And with that, I will introduce two wonderful guests today. Just confirming that you can see my screen. Yep, okay, great. So today we'll be talking about race, equity, and health in the COVID era. And we have two wonderful guests. We're joined by Dr. David Hayes-Bautista, who's an old friend and a wonderful public health scientist. He's currently the Distinguished Professor of Medicine and Director of the Center for the Study of Latino Health and Culture, the David Geffen School of Medicine at UCLA, where he's been since 1987, where he came from UCLA. Dr. Hayes-Bautista's research has appeared in wonderful journals, including Family Medicine, the American Journal of Public Health, Family Practice, Academic Medicine, and Salud Pública de Mexico. He's written some wonderful books that I would encourage you to take a look at. One of my favorites is El Cinco de Mayo, an American tradition, published in 2012 from University of California Press. He also writes columns for the LA Times and L'Opinion. And he is just an outstanding scholar, and we are so pleased to have Dr. Hayes-Bautista join us today. Also joining us is Dr. Mark Weiland, who is a professor of medicine and chair of the Division of Community Internal Medicine at the Mayo Clinic in Rochester, Minnesota, where he is a practicing primary care physician. Having trained in medicine and public health, his clinical and research interests lie in health promotion through community participation and research aimed at the reduction of health inequities. With funding from the National Institutes of Health, he has led research to improve community health with local solutions, and we'll be hearing about some of that work today. And Dr. Weiland, we are so pleased that you are here with us today. So I am not going to spend a whole lot of time talking. I'm going to minimize my time with you all today so you can hear from our two amazing guests. But I want to situate us a little bit historically. Now, for those of you who know my work, I am trained as a historian and ethicist of public health and do work that relates to the use of race as a variable in health research, and frankly, its use and misuse over the last century plus. But I want to introduce you to, or I hope that most of you know, who this incredible gentleman is. This is W.E.B. Du Bois, a sociologist and civil rights leader who worked on health as well as many other issues facing both the African-American community in the United States, also civil rights issues across the United States and globally later in his career. As a sociologist, Du Bois started out in my former home of Philadelphia, where I recently came to Arizona from. And in 1896, Du Bois was brought to the city of Philadelphia to study the Black population there in what was one of the first and most important studies of urban health and poverty in the United States. Du Bois studied an area in Philadelphia called the 7th Ward. And it was the first, as I said, systematic academic study of urban poor and race in America. He conducted the study himself. He walked the 7th Ward collecting the data. He would rise early every morning and hit the sidewalks of Philadelphia and knock on doors to interview people, conduct interviews and surveys. And he went house to house, drawing on census and other data as well, using statistical and other both quantitative and qualitative analyses. It was essentially a walking GIS machine. And for those of you who are familiar with Philly, and I'm going to show you a map in just a second, he walked from Spruce to South and from 7th to the Schuylkill, covering a tremendous amount of ground. And he did 835 hours of interviewing in 2,500 households, accounting for 10,000 people in over 3 months of data collection. For those of us who do qualitative or mixed methods research, that is an extraordinary feat. And I share this with you today because one of the major challenges, as we'll see in a moment, in both health disparities research and how we're thinking about COVID these days, is the use of social determinants data, which Du Bois in the late 1890s developed the research tools that many of us continue to use today, these mixed methods research tools. Here's a map with color coding of all the homes that he visited across those 3 months. And I just want to briefly talk about, to set the stage for our discussion today, about how Du Bois understood disparities. First, he placed the disparities he examined in a broader organic context. He believed that disparities were rooted in class and race-based structures, both internal and external to the community that he was studying in Philadelphia in the 1890s, and structures that were doing great harm to this community. He believed that historical forces played an important role in understanding health disparities. And as he wrote in his book in 1898 on Philadelphia, a glance at the table shows how much more sensitive the lower classes of a population are to the great social changes than the rest of the group. And I want you to remember that quote because it really has important meaning as we're thinking about equity and COVID and health disparities today. Du Bois also at this time started writing about the idea of race and how it was being used and misused in scientific thought. And he wrote, Americans are eagerly and often bitterly discussing race problems because they are behind the scientific times. He said, the world was thinking wrong about race because it didn't know it. The ultimate evil was stupidity, and he believed that scientific fact could help correct that. He also attacked the category of whiteness, writing, it may smack of heresy to assert in the face of the teaching of all of our textbooks on geography and history that there is no single or European white race of men, yet that is the plain truth. He did a similar attack on the category of blackness, that the human species so shade and mingle with each other that it is impossible to draw a color line between black and other races. And finally, he rebutted claims of black inferiority, which were quickly becoming biologically or genetically driven. And he wrote that disparities in health were an index of a social condition. You can read more about Du Bois in a great book by Alden Morris called The Scholar Denied, and a book that I wrote about 7 years ago called Race Unmasked. Spent a lot of time talking about Du Bois and his role in shaping our understanding of race and disparities in the 20th century. Now, Du Bois, of course, was laying the groundwork for what will become a century of work in the social determinants of health. These are non-biological health determinants like education, social and community context, health and healthcare, and so on, that provide the context in which people live their lives, and that those broader currents can influence health outcomes tremendously, as we know. So I just want to say quickly that some of my work, which builds off the work of Du Bois over a century ago, builds on the idea that race as a biological construct is a very poor way to understand and describe populations, and a very poor way to understand and describe disparities between populations. So we published a paper in Science calling on the NIH to take race out of human genetics and come up with better ways to study human populations. And we published a follow-up paper in 2020 in the wake of the murders of George Floyd and Breonna Taylor, calling upon the NIH to confront the use of race in science. We did so particularly in the wake of COVID, because Black, Latino, Indigenous, and other communities of color were essentially being biologized in the context of COVID because of higher rates of COVID in those communities early in the pandemic. And we argued that race is a poor proxy and that these types of both popular and scientific claims were both harmful to the communities that were involved in these claims, but also very harmful to the public's health. So that's the broader context that I want to set up. I will say briefly that, I'm going to end my slides right here, that the NIH has really been struggling with these issues for at least a decade now, particularly in the context of health disparities research. And as you'll hear from Dr. Batista in a moment, both the NIH, biology and science, both public health included, really need to rethink how we are studying and describing populations, because that description has a tremendous bearing on health outcomes, not just on what we do as scientists. So thanks, and I'm going to turn the mic over now and the screen over to Dr. Hayes Batista. Welcome, David.
Thank you so much, Michael. And let me just modestly mention that Michael and I co-authored a paper that just came out about 2 months ago on this very issue of the use of these racial categories in mortality research. I think it's a great paper. So I want to chat a little bit about going on beyond race to racial narratives, about how we conceptualize, talk about, then legislate race, COVID-19, and equality. Early in the pandemic, this is from April of a year and a half ago, it was clear that populations of color, particularly Blacks and Hispanics, were suffering more from COVID than of the non-Hispanic white group. In fact, this is the age-specific death rate for age 50 to 64 a year ago, July 8th, and this pattern has pretty much remained the same. This is the non-Hispanic white rate per 100,000, and Asian is higher, American Indian, Alaska Native is higher, Native Hawaiian is higher, Black is higher, and Latino is higher. Why is it that all these populations of color would mysteriously have higher mortality rates due to COVID? Well, in particular, the group that was almost the outlier, except it's 40% of California, why was the Latino death rate so high? Well, here is something we need to remember. It's about the philosophy of science. Facts tell different stories depending on who is picking them and placing them in a narrative line. So let's take a look at COVID. There is a narrative, a very deep-seated narrative about Latino dysfunction. Latinos just can't do anything right. They don't have enough documentation, they're always on welfare, they're gangbangers, et cetera, et cetera. I'm sure you're familiar with it. And this narrative was immediately brought into play with COVID. Now, some of the early clinical reports from China, from Italy, pointed out that once a person was in the intensive care unit, once they're ventilated, comorbidities would seem to lead to higher mortality. And a couple of the comorbidities seen early on were obesity and type 2 diabetes. Well, what do we know, quote unquote, about Latino health? Well, probably the one thing everybody knows, Latinos are fat, obesity. Well, everybody is obese, but that's somehow it's become a special property of Latinos. Secondly, Latinos are known to have higher diabetes rates, but not just Latinos, also Asians and Blacks have higher diabetes rates. Oh, but thirdly, now we bring in cultural inhibitions. Latinos, oh my God, they love to hug, kiss, have big meals, no wonder. And they don't like to wear masks. And then, of course, the immigration card. Here's when the previous administration needed to protect the jobs of our great American citizens, thereby signing an executive order temporarily suspending immigration into the United States. So this is that narrative. Latinos are dysfunctional. We just need to protect ourselves from that dysfunction. There's not much we can do about the dysfunction. Well, I embrace my lived experience as a Latino born here in California, having lived through a lot of stuff. And I just embrace it. And it has led me to see the same data, and I come to a different conclusion. Remember, facts tell different stories, depending on who is picking them and placing them in a narrative line. I looked at the same data, and I saw a different narrative line. One of which was that, in fact, many Latinos were essential workers. They weren't clinical, they weren't physicians, they weren't nurses, but they're the essential workers who kept the California economy going during the pandemic, such as farm workers, for Pete's sake. If it weren't for farm workers, we would not have been able to eat. If you remember the first couple of months of the pandemic shutdown, when people would go to grocery stores and they were fighting in the aisles over the last roll of toilet paper or paper towels. I keep telling them if it weren't for farm workers who are exposing themselves to a coronavirus every day, you would have been fighting over the last sack of potatoes in the store, and that would have been some very serious fighting. But the farm workers went out to the fields every single day, or they went to the packing house and they worked shoulder to shoulder, or they showed up to check out groceries online. As you look at this worker, now this was already a month into the shutdown, and here this worker in a shift would have over 200 clients pass within an arm's length, and she noticed she doesn't have a mask. The stores did not supply personal protective equipment because we didn't see these as essential workers. But the essential workers realized they needed PPE, we just didn't supply it to them. And not just farm work in the food industry, the ones who clean the offices, the nursing home attendants, automobile mechanics, construction workers, I mean, a whole host of gardeners, a host of occupations and industries were very essential to keeping the economy going, but we never noticed them. So we didn't care if they had PPE or not. And of course, within you have the indigenous communities who are even more unprotected because they're simply more invisible. So we have essential workers, but they were not recognized as such. They tend to get paid very little, which in a fee-for-service world becomes a problem very quickly. This is an article from a Spanish language newspaper here in Los Angeles, La Opinión. It's almost shortly to celebrate its 100th anniversary, that Latinos in the Central Valley working for full-time were not even earning minimum wage. Because of that minimum wage, housing costs, they're horrible in California, they're horrible in Arizona, very, very high. So one of the ways what this forces Latino families to do, particularly low income, is you put more people into a house. And of course, coronavirus loves more people in a house. And we tend to have more three-generational families, grandparents, parents, children. Then we have the lack of insurance. Even after Affordable Care Act, Latinos are twice as likely not to have insurance compared to other populations. But they have low income, so they don't have a lot of discretionary out of pocket for paying for cost. For example, a test, if it's regulated, costs $100. And if it's not regulated, it costs over $2,000. Well, an average farm working family has $1,500 a month income. So just to test everybody takes half your income. So do you test or do you rather pay rent? That's not too difficult to see what a lot of farmers wind up having to do. Add to that the Latino physician shortage. If you remember the early days of the pandemic, you actually had to get a doctor's approval to go get tested. And the LA Lakers, of course, they got tested immediately. Hollywood stars got tested immediately because they had access to physicians. So here's actually an empty word of advice from the state of California in Spanish, that if you have these symptoms, you have the high temperature forehead, you have the raspy cough, debe comunicarse con su proveedor médico de inmediato. You should call your medical provider immediately. But the problem is, because of the Latino physician shortage, there are any providers in these shortage areas. So how do you call a physician and talk to them? And how do you even more find a physician who speaks Spanish? And some people say, well, given 30 years, everyone's going to speak English. Well, no, actually, for 252 years, every single day, medical services have been provided in Spanish in California. It's simply part of California history. It's part of Arizona history. It's New Mexico history. It's Texas history. It's Colorado history. Spanish is simply part of where we are, period. So it's nothing new. Add to that then the immigration policies that only exacerbated the situation in some of the countries of origin. The immigration service, oh, you can hardly see the translation way up at the top, didn't stop during the migration, during the pandemic. Here's a tragic case in Colorado where a man was admitted full-blown with COVID. The migra went in, picked him up, and took him out of the hospital. Now, I don't know what happened. The story never finished that part, but for Pete's sake, you're going to the hospital, picking up somebody who's already sick with COVID, taking them out, and I'm sure he didn't have a lot of PPE. And with some of our immigration policies that we're seeing tragically outside of Del Rio today with immigrants from Haiti, we deport them. even knowing that they're infected with COVID. And sometimes they were infected with COVID here and they were deporting them down to Mexico, Central America, to the Caribbean, and then wondering why these countries have high rates of COVID. And when we came to the first CARES package of a year ago, last July, households that had a non-citizen, not necessarily undocumented, just a non-citizen, could be someone with a visa, a green card, whatever else, the entire household was excluded from participating in that first relief package. So I saw something very different. I didn't see Latino dysfunction. I saw that Latinos were functioning very much. They were showing up for their job, even though they were getting hammered by COVID. And the systems, the institutions were failing them at every step of the way in terms of wages, insurance coverage, personal protective equipment, access to detection, access to diagnosis, access to care. From beginning to end, the system dysfunctioned. The protective measures that we utilized 18 months ago worked very well in Beverly Hills, where you have the type of job you can unplug your laptop, stay at home. Oh, guess what? You're going to get a paycheck every month, whether you're in the office or not. That worked very well. If you're a farm worker, in first place, you can't grow strawberries in your front room. You have to actually be out in the field. If you don't show up for work, you don't get paid. You don't get paid, you don't eat. It's that simple. So these measures weren't appropriate for large swaths of incomes, occupations, and industries in California. The system failed to protect them. Remember, facts tell different stories depending on who is picking them and placing them in a narrative line. This is why we need to bring new and subaltern experience, lived experiences into the research world, into the professional world, provided with voice, so that when decisions are made for the next pandemic, and there will be another pandemic, how do we protect the public from this pandemic? After we've taken care of Beverly Hills, we need someone in the room to raise their hand and say, well, what about my population that has to go out and work in the fields? How do we give them similar levels of protection? So as of this year, in fact, we look here in one of our recent reports over the fall wave. This is non-Hispanic white mortality. This is Latino. This is age specific per 100,000. And the Latino rate just skyrocketed as Latinos continued to go to work, continued to come back to overcrowded housing, continued not to have health insurance, and COVID just ravaged the population. The cost of inequality, many Latinos discovered, was death. Thank you very much. Back to you, Michael.
Dr. Hitz-Batista, thank you so much for such an important talk filled with so many interesting ideas that we're going to circle back to after we hear from Dr. Mark Weiland. So I'm going to turn it over to you, Mark, and thank you again, David. And we'll be back with some questions in a few minutes.
Okay, do you see that as a slide there?
Yeah.
Yep.
Okay, so I'm going to talk a bit about a community academic partnership called Rochester Healthy Community Partnership, just as a point of introduction, and then highlight the group's work in response to the COVID pandemic. And I realize that this is a Minnesota-based example, but there's really no part of it that's tailored by geography. And really the framing here is to provide an example of community co-leadership in shaping the regional pandemic equity landscape and the unique role that community academic partnerships can play in this response. So RHCP is a 16-year community academic partnership that operates through a community-based participatory research framework, which is an approach to research whereby community members, community-based organizations, academics partner in an equitable way through every phase of the research process. So all the way from what is it we're going to work on together on through to analysis and dissemination of data. And this participatory intervention work gets at complexity in public health in ways that a traditional reductionist approach to research sometimes cannot. And this slide kind of demonstrates the circuitous current research agenda of RHCP. And we've collaborated with the University of New Mexico Center for Participatory Research in their Engage for Equity campaign for several years. And in, I guess, a few years ago, we partnered with them for an in-depth partnership evaluation, which culminated in part with the adoption of this RHCP CVPR conceptual model, which directly links context and especially partnership dynamics to research and health equity outcomes. And our kind of big take-home point from the evaluation is that process is the most important product, so that if we skimp on certain partnership dynamics in particular, then the outcomes will suffer. This is clearly a pre-COVID collage of physical proximity here. About 18 months ago, COVID disparities were coming to light across the country as well as here in Southeast Minnesota. And so RHCP community partners observed that credible COVID information was being produced across many languages, but it wasn't consistently reaching immigrant communities with limited English proficiency. So partners thought about how we could leverage RHCP's community-based infrastructure to fill these gaps. And we think that these kind of partnerships that operate through CBPR or community engaged research more broadly are really well poised to assess and respond to the pandemic because of, one, pre-existing trusting relationships, and two, community partners who have the organizational and technical experience to reach and collaborate with community members during the crisis, particularly in the context of justifiable legacy of mistrust of health institutions in some communities. And community engagement is essential in the COVID response because COVID disparities are framed by this complex web of contributing factors that we've heard about today that stem from a distorted distribution of social determinants of health, social injustice, and the fact of structural racism. This is a figure from our commentary in clinical infectious diseases, and I won't go into it in any detail because Dr. Hayes Bautista covered this beautifully. So in addressing the lack of credible information reaching populations represented by our community partners, we adapted the CDC Crisis and Emergency Risk Communication Framework, which can be used to encourage public participation in prevention and containment. But we added what we think was a critical bidirectional component with community partners. So we started by co-creating messages across three constructs. So it was COVID prevention and containment, which now includes vaccination, testing, and then socioeconomic impacts. And then as facts changed, like they did often and continue to, the same process is used to refine messages and build new ones. So we continue to co-create about 2 or 3 messages every week with community partners. They're disseminated by communication leaders who were recruited by RHCP communication leaders for their credibility essentially within networks. And then the important thing is that these communication leaders also solicit community health and socioeconomic concerns through the same platform. And so this bidirectional communication with community members is then used by RHCP to kind of enhance subsequent messaging, to leverage resources to meet community needs, and importantly to advise regional decision makers. And so the way that worked was that communication leaders came together virtually with RHCP community and academic partners initially every day, for the first, when none of, when we were all trying to figure out what was going on, and then twice weekly, and now we're meeting every other week. So medical questions that they were hearing, for example, could usually be answered in real time by academic partners, and socioeconomic questions could be answered by community experts. And the resources could be leveraged on the basis of need via referrals to community-based organizations. And then the collective voices of this group were used to influence regional testing policies. They were used to influence vaccine allocation strategies, as well as just 2 examples. So as an example of reach, in just the first 2 weeks of the program in late March 2020, 26 communication leaders reached about 10,000 individuals across 6 languages through 9 different communication platforms. And this has continued to expand, and we've continued to track these data and expand other arenas, including most recently vaccinations. And we mapped qualitative process data to the CDC framework, which has informed the ongoing work from there that's sprouted into several different working groups. And the risk communication framework has proven sustainable here in Southeast Minnesota and has expanded to other partnerships in Southern Minnesota, in Florida, in Southwest Minnesota through Mayo Clinic Primary Care Practices, and then with partners at the University of Mississippi who received CDC funding to implement this intervention in the 3 counties with the widest COVID disparities in that state. Most of the COVID messaging was achieved through social network effect, starting with communication leaders, but the RHCP social media footprint has also grown with COVID as another less personal and less effective way of disseminating messages. And likewise for a We Are RHCP COVID-19 campaign in collaboration with the city and county that showed up on, when you're searching Google in certain locations throughout the city and county, as an example, and billboards. Now, for vaccinations, RHCP has implemented 2 strategies. The first is to apply the bidirectional risk communication framework to promote vaccination of health disparity groups who have been disproportionately affected, and then to directly address vaccine logistical hurdles, which is really the big one, especially early on. So we develop messages and disseminate them in the same way I described earlier. These messages address issues of vaccine hesitancy and that were identified in listening sessions with communication leaders, and logistical issues about the where, when, how, and what to expect about vaccination. And then to fill gaps for community members who are hesitant to have their vaccine in traditional clinical settings, RCP developed its own community-based vaccine clinics. Communication leaders signed up participants on sort of their, a Google scheduling template, and then Mayo Clinic provided the vaccines at community locations of their choice in a series of 7 events. And so, our ongoing mixed methods process evaluation has identified intervention components, implementation processes, and impact mechanisms that I've described, and then culminating in outcomes relative to acceptability, feasibility, perceived efficacy, reach, engagement, adaption, and sustainability. So we conclude that at least at this phase, because obviously this work is ongoing and it remains sort of reactive and scrappy, but we conclude that the pilot and implementation studies have demonstrated feasibility, acceptability, reach, sustainability, scalability, and perceived efficacy of this approach, and that community engaged partnerships through a CBPR or community engaged research more broadly in those frameworks are especially well poised to respond to pandemic risk communication needs with populations at risk for disparities. I just want to acknowledge the RCP COVID-19 working group. I'll stop sharing.
Outstanding. Thank you, Mark. Thank you, David. Now's a great time for folks to pop questions into the Q&A box. We've got 2 so far, but I'm gonna use my position as host to throw out just sort of a question. But going back to a quote that I read from Du Bois's work in 1898, talks about how much more sensitive the lower classes of a population are to the great social changes than the rest of the group, something that is implicit in all of our work here that we've spoken about today. So that was over 100 years ago, 123 years ago that book was published. Why are we stuck in this sort of doom loop of understanding disparities in what I would argue is not a particularly constructive way? And with work like both of yours that is consistently at the forefront of research like this, how do we get out of this? Why are we stuck? And I'd open it up to hear your thoughts.
Well, if I can jump in, this is why I'm a great proponent. First of all, we need to see more diversity in academic medicine, and in the research laboratories, in the PIs. However, just diversity alone doesn't change anything. That diversity has got to develop its voice to bring in its own lived experience and place that on the table so that it can compete along with other narratives at the table. As I mentioned, the narrative around the table in this country, by and large, in the early days of the pandemic, was very good for Beverly Hills. It fit the lived experience of people in Beverly Hills that could unplug their laptop, could sit in their living rooms, could have everybody else bring things into them. That's wonderful. It left off the table those who were not able to do that and didn't even offer them any protection. We need diversity with voice to raise their hands at that point and say, great, now let's talk about these other communities. We need to protect them all. We've had one dominant racial narrative in this country for 230 years. We need some subaltern racial narratives to be developed and take their place at the table.
Thank you, David. Mark, you want to jump in on that, or should we open it up to more questions?
No, I think I don't have much to add other than, from a community engagement perspective, we need, like in the clinical setting, for example, we have such a problem of sort of an authoritarian approach that lacks, lacks diversity. And so what the broad picture is that we need community informing practice rather than the other way around. And that's what, we're trying to do in a clinical setting. And certainly from a public health and a policy perspective, we need to double down on that concept that originates from the community engagement constructs.
Great. Thank you both. So the first question is actually a comment that I'm going to read from V. Clark 8. And it says, thank you for this perspective. Most of my Spanish speaking family and friends have had COVID, most at work as essential workers or by family members who were essential workers. They have been some of the heroes of the pandemic. So thank you for that comment. And from David Sklar here at the College of Health Solutions, Dr. Sklar writes, sometimes miscommunication is not due to lack of knowledge, but due to different interests and priorities. We also do not use language and concepts that connect with our audiences. How can we better communicate with the public and in particular underrepresented groups?
Well, as I suggested earlier, there are two things we can do. One is we need to increase the diversity at the professional level and make sure they have developed their voice. So they're just not mutely accepting what everyone says, but they can raise their hands and challenge the process. Secondly, we need to work with those institutions that have been in these communities for over 170 years, the community clinics, the neighborhood organizations, et cetera. They're already out there. They're on the ground. People know them, and they would be wonderfully effective. California really didn't get a handle on vaccination amongst Latinos until it finally started working with the community clinics. Then the vaccination levels rose tremendously. So there are answers out there, but we need to recognize them and work with them. But right now, the dominant racial narrative blinds people to their existence.
Thanks, David. Mark, you want to jump in?
Yeah, well, obviously I'm biased, but I think we clearly need to rigorously adopt empirically derived communication frameworks and disseminate them through trusted messengers, and that implies changes at the policy level all the way down to very pragmatic, evidence-based approaches.
So let me push a little further on this, because I think you spoke about scientifically driven ideas being pushed out into the world. We are facing an avalanche of misinformation, particularly about COVID at the moment, never mind about the nature of health disparities. In both of your roles, how do you push back against the level of misinformation that is ubiquitous, whether it be on Facebook or even in both old and new media? There's a whole lot of misinformation out there that we are drowning in. How do you push back against that, particularly in this context?
Mark, jump on that.
It is a challenge, and I'll say in my role as a primary care physician, I've never seen misinformation to this level that transcends the clinic. For example, my patient will accept implicitly what I'm telling them for high stakes interventions, in a medical context. But then when it says, oh, and by the way, let's get you that COVID vaccine, absolutely not, and there's no, and so that has been set, and facts, even from me as a trusted messenger to my primary care patients is a challenge. So there's obviously some really structural factors and societal factors that are at play. But I still think that doubling down on this, at a regional level anyway, dissemination of facts through trusted messengers, through an infrastructure that existed before crisis, can be leveraged to just continue to permeate.
And if I can expand on that just a little bit, this pandemic was unique in that the very measures to prevent it were highly politicized, almost from the very beginning. Unlike, say, with Ebola. During the Ebola crisis, no one said, rip off your hazmat suits. No one said that. But in this, from the very beginning, the very basic public health measures were politicized and reframed as they're infringing upon your freedom. And people just seem to forget, you are free to drink. You are free to drink until you're drunk. You are not then free to get in a car and drive 85 miles on the freeway. You will be stopped, you'll be arrested, you'll be put in jail, you'll be fined, you'll have your license taken away. And nobody says that's infringing on freedom, because there is a greater public good. So the reframing from a very political level has made this really, really difficult to get the basic message across, and then to push against the disinformation, so that now people are taking horse medicines because they think it will offer better protection than a vaccine, or they're sniffing what are the not carbolic acid, hydrogen peroxide, because that's supposed to, doing all sorts of interesting things that have absolutely not one shred of evidence for them, but it's come to that level. And there's some sense that there's a whole community out there that supports that other narrative, that this is taking away your freedom. So this makes it very different from Zika, from Ebola, from all these other pandemics we had in the past.
And it's uniquely American, I think, at least in part. If Canada, for example, has a liberal party, they have a conservative party, but party allegiance doesn't predict where the wearing of masks, physical distancing, and vaccine uptake like it does in the United States as the most powerful predictor.
And to your point, by the way, Michael, this very narrative also is very tied to racialization of the population. So these things seem to have come together in a very deadly way.
Yeah, I mean, I think you mentioned ivermectin a few moments ago, which is a horse dewormer that can be used in humans. And Mark, will turn to you if you want to comment on the rare circumstances when it's used. But what is amazing to me is that people will take a horse dewormer, wear a diaper, get sick, and not put a vaccine in their arm that has, 70% of Americans have done so with a very high safety record and a very effective vaccine. And this is sort of, where we are. So we have a whole lot of questions in the chat box now, the Q&A box, I'm sorry, and I'm going to turn to some of those. Bridget Murphy asks, could you talk a bit about what Crenshaw defines as intersectionality in COVID-19 and how I guess the nature of intersectionality in the context of a pandemic is an interesting and important idea to think about. Anybody want to jump on that?
Yeah, it's interesting because when we look at chronic diseases, heart disease, cancer, stroke, etc., actually across the country, there is this phenomenon called the Latino epidemiological paradox, that Latinos have 30% lower age-adjusted mortality rate for heart disease compared to white, about 30% lower cancer, 40% lower chronic lower respiratory, etc. Now, these are lifestyle diseases. That is, they're the culmination of years of how you live, what you eat, whom you associate with, and they're chronic. I cannot breathe on you and give you a heart attack. That is the culmination of years of your lifestyle. And Latinos seem to have an interesting lifestyle that protects them. It actually adds 3.5 years to Latino life. However, communicable is very different. Communicable is a great indicator of how tightly connected you are or how disconnected you are from the major healthcare institutions. And COVID showed this with a vengeance. So it's clear there's intersectionality such that chronic diseases, actually Latinos do quite well, but communicable, where you actually need access to care, wallops these sorts of underserved communities over and over and over and over again. So there's an interesting intersectionality just between the chronic and the communicable, much less the industry and occupation and everything else.
Great. Let's turn to another question. This is a quick question, for Dr. Weiland. Where can we find more information about the RHCP-CBPR conceptual model and this communication framework?
You could go to our website, which is rochesterhealthy.org.
Great. Thank you. From Swapna Reddy, who's a faculty member here at the College of Health Solutions, she asks, or she says, we've seen great strides in COVID-19 vaccine rates among Native and Indigenous populations recently, communities that experience some of the highest rates of infection and death, especially here in Arizona. Also populations with high levels of distrust with the healthcare system and limitations to and access issues. What lessons can we learn from the successes in this population to improve vaccine rates in other communities? Any thoughts on that?
Well, interestingly enough, I was doing some work on the health HCAHPS, the healthcare assessment, health consumer assessment of health systems and providers. And interestingly, American Indians rate their hospital experience very high. Well, it turns out for all the lacks and everything else, there is an institution, the Indian Health Service, dedicated to providing health. Does it do the best job it could? No, it's been hamstrung for years. So at least having a provider that you are connected with, even if it's somewhat tenuous, seems to really engender a lot of positive feelings. Whereas when you have populations that don't even have that, and sometimes have been actually the targets of that, such as the sterilizations here at LA County just as recently as 35 years ago, we can see why other folks, first of all, might have some doubts about should I go there or not. Plus, you have the disconnect of simple location that maybe there's nothing there. So how do you get confidence built? How do you get a message out there when this community has been ignored for 170 years? We're talking about history here. as W.E.B. Du Bois pointed out, there's a history involved in all these things. Not like this just suddenly happened in the past 18 months. And we need to address that history now to be prepared for the next pandemic. There will be another one.
Mark, anything you want to add to that?
Well, just to piggyback on that, I don't know the details of this, but my understanding of some of the successes in the Navajo Nation have to do with the fact that the interventions were not top down, like they were, early in the pandemic when it came to testing, and there were some lessons learned from that, and the funding really went to grassroots organization that had a history of organizing in local communities and tribes.
Great, thank you. I've got a couple more questions in the box. Question about gaps in knowledge relating to pregnancy and vaccine hesitancy, especially in immigrant communities. Do either of you know anything about that data?
No.
I don't know a relative specific to immigrant communities. No, I will say that that's were some of the misperceptions that we addressed in a couple of our messages early on when the data were still relatively premature, and then of course now they've been very concrete, and so we just continue to message that.
Great, thanks. A few more questions, and we've still got about 10 minutes left. So if you have a question, please put it in the chat box. There's a question here from Layla Saeed Hollister about healthcare providers facing abuse from patients due to the ideological divide between vaccinated and unvaccinated populations. And wondering if this is disproportionately impacting BIPOC caregivers, and how might institutional DEI programs combat such efforts, not just sort of the institutional challenges, but what institutions face from the public coming in, especially in circumstances like this.
Well, this expands way on beyond the hospital. We're seeing the breakdown of civil society situation apparently in New York just a couple of days ago, where this family from Texas, where vaccine and mask wearing rates are pretty low, were asked to show proof of vaccination, so they beat up on the host that was trying to seat them.
Dave, let me jump in on that, because there was actually a follow-up to that story that suggested that the hostess was aggressive with that family and had potentially uttered some nasty things to them. So that story's gotten more complicated, but there are other examples of that, not involving the New York City host issues. So absolutely.
Mm-hmm. And even to the point where some first responders here in California, there's some cities where up to 40% of first responders refuse the vaccination, or even hospital workers. And it depends. Some hospitals, like the one I work with, 96% vaccinated. Other hospitals, about 40, 50% vaccinated. So this, again, has become a highly politicized thing. And then because of the nature of that politicization, there's just not a lot of civil interaction between these two differing schools of opinion about vaccination, distancing, and mask wearing, that there seems to be very little ability to compromise. And this has been driven by political agendas for the past 4 years at least. And actually, depending on where you're looking at, you can go back 230 years once you bring in the racial narrative.
Yeah, I mean, as historians, you and I know this goes unfortunately way back. And if I can piggyback on your answer, just to again push sort of the first question that I asked after that related to, we're still in this, 100+ years later from Du Bois's statements on understanding disparities sociologically rather than biologically. What do you think next steps are institutionally for pushing back against this? David, you and I have been involved in some work trying to help the National Institutes of Health rethink how populations are described, and the needle has not yet moved, despite the new Unite initiative from the NIH, which focuses more on structural racism internally at NIH and recruiting more underrepresented minority scientists, both intra and extramurally, into NIH, but still doesn't touch the issue of how we study populations and whether social determinants and environmental determinants should be privileged over biological determinants. So wondering if you both have some thoughts on where we might go next in rethinking how we obviously we do this kind of work, but how do we push this out more widely to either our colleagues on the clinical side or even, on the social science side where there's still a lot of struggle on this topic?
Well, the dominant racial narrative is pretty much baked into the research that we do, the models, theoretical models that we use, how we collect data, what we do with them. As I kept pointing out, yes, facts are there, but who picks them and puts them in a narrative line? And there is this dominant narrative about minority dysfunction. But there are alternative narratives that need to be developed, equipped with voice, put at the table so that we have a wider variety of tools and models, different ways of looking at society, different ways of describing human sameness and difference. There's more than just black and white and brown. There are other ways which other societies have done this. So we need to learn from the world around us. And I'm a great believer in the up and coming generation. In California, 75% of school-aged children are what we used to call minorities. 75%. I mean, that's beyond a supermajority. And they are dating each other, they're pairing up with each other, they're having babies who are very racially ambiguous. They will, by their very sheer number, cause us as researchers to rethink, why do we use these race categories? What are we trying to do with them anyway? And are there better ways to talk about human sameness and difference?
Thanks, David. Mark, anything you want to add to that?
Just to echo that, because race is socially constructed, it still has its place in the epidemiologic construct and clinical trial context. As we develop cultures to thwart that, the implications of that social construct. But what's more pernicious is that it's being applied in ways that race should have nothing to do with it relative to ancestry or other ways of categorization. Just as one small example in the clinical setting, the fact that we calculate the glomerular filtration rate, which is a measure of kidney function, differently in African Americans than we do in white populations is incorrect and obviously is implying a race as a biological construct rather than ancestry or or other factors. So in other words, there are many situations where it's being used in kind of high stakes clinical contexts, and those are some low hanging fruit that I think we need to work on as clinical institutions.
Yeah, I think that's an important point. There have been some really important papers. There was a paper in the New England Journal of Medicine in 2020 identifying, I think, all of the race corrections used in the clinic still. But we're starting to see a little change on that front. Some hospital systems are removing the kidney race correction, but there are many others that are still in use: lung function, some heart tests, VBACs. There's a race correction for VBAC. So it is ubiquitous in medicine, and it is, as both of you have said, low hanging fruit to start to push the idea of biological race out of both the clinic and science more broadly. We have just a couple more minutes, and I want to jump to a few remaining questions. Dr. Kevin Koros asks, can you speak on the continued risk for underrepresented populations with the moratorium on evictions having been overturned by the Supreme Court? And this, of course, is talking about, during COVID, there were moratoriums on evictions across the country. The Biden administration tried to extend that and was recently thwarted by a Supreme Court ruling. So this places people at risk, particularly in the context of COVID. David or Mark, any thoughts on that?
And then we complain about homeless. I mean, we were manufacturing another homeless population, and unfortunately during a pandemic, which could eventually maybe affect all of us, because we're just dumping people out on the sidewalk. It was hard enough to maintain distancing. It was hard enough to maintain quarantining if you were exposed. How do you do it when you're homeless? And then we're going to increase the homeless population.
We've got just 3 more minutes. We've got a couple more questions. I'm just going to go through them given our time limitations. One question is about what should governments, whether state, local or federal, be doing to communicate and help more of the populations? And should we be relying more on non-governmental entities like nonprofits to fill the gap, especially with a lot of the confusion coming out of the Centers for Disease Control in terms of health comm throughout the pandemic? Another question about attracting minority physicians and scientists, given some of the difficulties in both credentialing that are difficult both for minority students and more traditional students. And then finally, a question about whether those on the front lines, particularly, David, the populations you were talking about in your talk, are more likely to mask and get vaccinated, or are the statistics pretty similar to some of the national trends? So maybe start with that one, David.
Okay, well, actually, I can combine the two. As you know, there's a great amount of state variation in this, a huge amount on vaccination, messaging, requirements. And some states actually have prohibited districts like a school district from making a mandate for vaccination or wearing a mask. So clearly, the outcomes in those states, and we're seeing it very clearly, is you're increasing your COVID infection rate, hospitalization, mortality, et cetera. So it's hard to talk about what can we do as a country in this situation. However, there's one thing as individuals, each and every one of us can do, which is if you're eligible, register and then vote. And if for whatever reason you're not eligible to register, find a friend who is eligible, who isn't registered, take that friend, register and vote. We saw how important just a few hundred votes made in the last national election. We had a recall vote in California, and in some rural areas, as few as double digit. We're talking about a few dozen votes made the difference. Register, vote, then perhaps we might start seeing some changes in how the governmental entities approach the COVID crisis.
Thank you, David. Mark, any final words before we close?
I think that's a good place to leave it.
Okay. Well, we are grateful to both Dr. Hayes Bautista and Dr. Weiland for joining us this afternoon. That's all we have time for today. We encourage you to follow the College of Health Solutions on social media, be Twitter or Instagram, so you can learn more about other opportunities to engage in dialogue with some amazing scientists like we had today. Our next Health Talks webinar is called The Heat, Effects and Risks of Climate on Health Outcomes, and will be Thursday, October 21st at noon, Arizona time. Registration will soon be open and available at asuhealthtalks.com. And again, a huge thanks, David, Mark, thank you for taking time out of your very busy days to share some thoughts on COVID inequalities and health disparities.
Thanks for the invitation. Appreciate it.
Thank you.
Always good to see you both. Thanks everybody for joining, and don't hesitate to reach out to us by email if you have additional questions or comments. So have a great day, everybody.